great pleasure, ladies and gentlemen, to welcome you here to the Society meeting tonight and to be invited by Caroline to organise the presentation. I think it's particularly good that everyone's turned out on such a freezing cold night, especially when Coronation Street is on. Careers are important, there's no doubt about that, and it's very nice that there's a lot of medical students here who are expecting to have some real words of wisdom. I think you will do, though, because we are lucky that we've got here with us tonight 8 doctors who are absolutely the apogee, the peak of their professions, acknowledged household names in Sneinton and Bulwell, who are here to tell us about their careers and about their choices. It is a balloon debate, as Caroline has said. I don't know if you've ever done a balloon debate before, but the balloons will gradually subside, and at the end of the first 8 presentations we will have a vote. We'll then be able to throw overboard some of the people that are holding the balloon down, and it will rise back up again. And I must thank Sharon Scriven, not only a urologist but a balloonist as well, who spent about 3 SPAs making that concoction. Thank you very much. So, as I've said, each of the 8 presenters will tell us about their career, their profession, what they think's good about it. They're going to have 3 slides, and they're going to talk for about 4 minutes. I want you to listen attentively. And then after that we will have a vote, and then that'll bat the 8 down to 3 finalists, who will then present again just 1 slide, and then there'll be the final vote. And we have there, at the end, underneath the balloon, the stunning prizes for our contestants tonight. So thank you again for coming. I'll just briefly introduce now the contestants. So we'll start off with the Medkai sponsored balloon floating as we speak over the medical school. And who are our presenters? Who have we got? We're starting off with Professor John Birchall from ENT, fabulous speaker. His hair is not natural. Will be followed by David Bogod, who's an advocate for anaesthesia. His hair is natural as far as we know. After that, we will pass on to Pritcha Hal, who's going to talk to us about general practice. His hair curiously looks false, but is real. And then, enormous pleasure to have been able to secure the services of Lizzie Didcock here, a former urology houseman, sadly diverted into something else afterwards. Here is the other balloon floating over the medical school at the moment, sponsored by Medkai, at a significant cost, I may add. The other 4 then are Tom McCulloch, who's ventured out from histopathology to be here. We've then got, after that, Simon Travis from the radiology. We've then got Angus Wallace here, the inventor of the coat hanger. And finally, but not least, who's travelled down from Kingsmill to be here with us tonight, we have Miss Sue Ward. So, John, would you like to take the stand, please?
Yeah. What have we done?
Nothing.
Sabotage.
Damn technology. Thank you, John.
Oh, how to get those things off the side? My time hasn't started.
Don't
yet.
worry.
This is,
No, don't worry.
I don't want to touch anything here. After the fire.
There we are.
Ah! But you take your glasses off. Right. Well, thank you for asking me to come here tonight. It's very simple why I did ENT. I just can't remember. I was too drunk. But when I woke up, it wasn't too bad. And the good things about ENT is that you do deal with adults and children. And if I get to the next round, you'll see why this is valid later, because this is where the attacks come in, which I'm better suited to. We do ears, noses, and throats. Now, some people have difficulty with this. Where's my bag? Oh, there it is. But just to help you, so I know there are medical students here. This is an ear, this is the other, this is the nose, and round the neck, that's the throat. And the surgery in the different bits are quite different, from gross, almost orthopedics, in some neck procedures, to very refined watchmaking in ears. I do the latter. It's quite good also because we do tend to work in teams. We have high volumes of patients. And unlike some specialties, we actually cure people. And people are grateful. They can hear again or walk again, which is funny in ENT. But we always take credit. Now, yes. Now, what's gone on in the last few years in ENT? Because a lot of people just think we sit there taking tonsils out or sucking snot out of noses. Now, some people do that, but they're called registrars. But there have been some major technological advances. The bone-anchored hearing aids, where we just actually stick pins in people's heads. They come out looking like a relative of Frankenstein. Cochlear implants have been a big development for kids who just couldn't hear at all, can actually use the phone. There's been a lot of work in middle ear prosthetics, improving how we can reconstruct middle ears. There's been a lot of work in recent times with voice restoration. And these sort of things are quite important to people, to be able to hear, to be able to talk. It's very important. Having a bit of a limp, Angus, doesn't matter. It's done you no harm. And then they do funny cancer things. Nasal reconstruction is quite an important one because you look better with a nose, or most people do. And they stick in free flaps and do all sorts of other funny stuff. But, as John Lemberger would have said, the past is a different country. Oh, wait, I've gone the wrong way. Right, now the future, because many of you are medical students, if it's all been done, what's the point? Now, some interesting areas, I think, are coming up, like the cochlea, forget implants and that stuff, that's all been done. But there's a lot of work now in animals with growth factors, getting the hair cells to grow and whatnot, and trying to manipulate them genetically. Middle ear stuff using biopolymers. One of my dreams is to get rid of mastoid cavities. It's like polyfiller that gets absorbed and bone grows in. And also, the thing is with this, you've got biochemical things, chemical things, but there's also physics things, like signal analysis is very interesting. I used to do some of this once. And this sort of stuff's very important for processors and so on, like cochlear implants, and that's still ongoing. A big question, though, is a lot of our stuff is mucosal inflammation, and we've not really got a long way with that, and that needs doing. Cancer will always be hanging around, but a lot of that will be done outside of the specialty. And tinnitus and balance, we're still not very good, so we need some bright people to sort that out. So there is a future and a pleasant past. And if you don't vote for me, you won't see Teddy again.
Well, that's great. Thank you very much, John, with those competition-winning slides there. Now, we're lucky enough to have got David Bogard to talk to us about anaesthesia and tell us exactly what it is that anaesthetists do with their time while surgeons are so busy. Sad, I think, it is that anaesthetists now are their own employees. Now, I remember the days when anaesthetists were actually employed by surgeons, and my goodness, that helped the lists go properly. David and I have been in Nottingham, actually, for years together, and have managed to avoid each other until John Bowley retired, and David's drawn the short straw to do my list on a Wednesday morning. And I'm grateful, because actually, he's not bad.
That's kind of you, John.
So thank you very much, David. Convince us that anaesthesia is a career to choose.
Thank you very much indeed, John. I can assure you that no cuddly animals will be harmed during this talk. The gentleman before you, Dr. John Snow. I'm sure you all recognised him. John Snow is known for many things. He is, to the best of my knowledge, and should this come up in a pub quiz, you may need to know it, the only lifelong teetotaler who has a pub named after him. He was also, of course, responsible for stopping the cholera outbreak in the East End of London, and Soho rather, which had claimed many lives by forcibly removing the handle from the Broad Street pump. But he is best known for being the first professional anaesthetist in the United Kingdom, and in that role for administering chloroform to Queen Victoria during the birth of Prince Leopold and subsequent royal children, and was responsible, really, for the overturning of the traditional view that childbirth was best done in pain and anguish. And John Snow is up there because he was voted the greatest doctor of all time by hospital doctor readers in 2003. And in voting him the greatest doctor of all time, he pipped into the silver medal position a chap called Hippocrates. Now, I don't anticipate you're all going to aspire to be like John Snow, but just to be an anaesthetist is pretty good going. We are responsible for an awful lot of work, and we take up about 7% of all training posts in the whole United Kingdom. Along with psychiatry and paediatrics, we're right up there as the top training specialty. If we lose us, if you chuck me out the balloon, a lot of you medical students are going to be without a job. But not just there's a lot of us training, we do a lot of work. This diagram is found in the Group of Anaesthetists training booklet, Who is the Anaesthetist? A guide to medical students, not to surgeons. And it's an 80-page long guide, and how many specialties produce a book for you like that? But notice the number of places where an anaesthetist can be found in the hospital nowadays, apart from the coffee room. The operating theatres, the recovery unit, the CT and MRI and interventional radiology units, on the wards preparing patients for theatre and reviewing sick patients for transfer to ITU, and of course in the intensive care unit and HDU, where they lead. Absolutely. The obstetric theatre where I work, and the maternity suite, pre-assessment clinics, and of course treating pain. Pain, probably the most feared complication and most feared long-term problem that patients have. The only people who have really taken it on the chin are anaesthetists, and of course we lead in resuscitation and education as well as transferring patients to the hospital from another hospital. We are responsible, according to the Audit Commission, or we see and involved in the care of 62% of inpatients in hospitals in the United Kingdom. If you get rid of us, a lot of my colleagues on the front row will not be able to do much. Angus in particular. What are you going to do, Angus? Just hold them down? It all comes to a conclusion, it seems to me, when you look at hospital at night. And don't tell this to the managers. I hope there are no managers here tonight. But Hospital at Night, you will remember, is a 2005 initiative to reduce the number of medical staff and nursing staff on at night to an irreducible minimum with a certain number of competencies which can deal with any non-elective situation occurring out of hours. Well, Hospital at Night listed 25 competencies for doctors. And of those 25 competencies, these are they. And 24 of them are in the basic and advanced syllabus of the Royal College of Anaesthetists, ladies and gentlemen. The only one that isn't is the one that you can see there, number 25. And frankly, how difficult can that be? So, ladies and gentlemen, I put it to you that the anaesthetist of all the specialties before you today is the true Renaissance doctor. Please vote anaesthesia. Thank you.
Well, thank you very much for that, I have to say, unconvincing performance, David. I'm still none the wiser about what you do with all your time. Pritchard Howell, Principal in General Practice, is now going to tell us about what's so really, really good about general practice and why almost all medical students do it and don't do urology, which is arguably the very best specialty, which is why we haven't presented it tonight. So, Prit, thank you very much.
Okay, thanks very much. Typical GP fashion, I actually like to make contact with my audience rather than hiding behind that's the over there. But Angus, you may well have a good reason to hide behind that later. Just to say that to reflect the demographic changes that we're experiencing in general practice in terms of recruitment, I was going to be dressed in drag and a skirt. Now, I don't need that. Can you hear me in the back? Thanks for, yes, apparently this is being podcast, so I better watch the language. Yes, but I was, thank you very much. I better slow down, haven't I? So I was going to wear a skirt and be in drag, but Angus has already beaten me to it. Stole my thunder. General practice, well, what are we? You know what? We are basically it. We are the real doctors. We are as old as the oldest profession. I wanted to use the word prostitute, but you say this is being podcast. If you hadn't told me that, I would have been fine. Now I can think about this all the time. Sex, sex, sex. Okay. Right. We represent 80% of the contact that patients make is with us. We are the real gatekeepers. In fact, we are, I can say the dam, but we are the dam that holds back this incredible volume of work, which my colleagues in the front row, if they were exposed to, they would surely drown. And therefore, our role is actually crucial to primary health care in this country. Not only that, but all the developing countries have realized that primary care is the direction to go. So our specialty, if you like, is sort of developing all over the world as being extremely important. In terms of, if I go to the next slide. Okay, what are we? We are a tool. But we're a multifunction tool where the guys at the front are often just one single tool. So we can be turned to any situation, even to take out sort of stones from Angus's shoes, I think. Yep. And to train this tool, whereas the rest of you all seem to need 5 to 7 years, we have such brilliant people entering general practice that we can do it in 3. So in other words, we can do all these specialties in 3 years. Instead of the 5 to 7 years that they take. And we have a fantastic training program, which is unrivaled in terms of its excellence, and particularly concentrating on consultation skills, which brings me on to the whole. This is where we score, where the rest of you see a bit of the moon, we see the whole of the moon. Water boys, by the way, those who don't know. So we basically see the whole person. And this is where we have our greatest strength. And we are so privileged in the sense that our lives cross so many other lives, and we affect change. And it's been one of the most rewarding career choices that I have ever made. And I actually have had a spell in secondary care, so I can actually make a comparison and say to you that basically the whole, and appreciation of the whole patient in a society and environment is actually crucial to primary care. And finally, I would say that throwing me out would be like sort of suicide for all of you. That dam would burst, and you really should keep me in, primarily to see a risky stunt that I plan to do should I get through to the second session and I've had a few drinks. Thank you.
Great, thanks, Prit. And I think even if you don't win, I think we've still got to see you on that ball, actually. So, it now gives me a great pleasure to hear Lizzie Didcock extol the virtues of paediatrics. As I said earlier, she started off in urology. Unfortunately, wasn't entirely captivated by it for reasons which are still unknown to me. But actually, after the birth of her 12th child, decided that actually she had to do paediatrics. So, thank you very much, Lizzie.
It's all right. I just need a pointer.
It's that little one there.
Okay, fantastic. Thank you. Right. In just 4 minutes then, no hesitation, deviation, repetition. Why paediatrics is the only career, obviously apart from urology, of course. First of all, at the top, oh my gosh, dogs at the top. Paediatrics is easy. Children are like animals. So when they're poorly, they lie down, and when they're better, they run around. If you're a male paediatrician, the top, you get to wear a Mickey Mouse tie, tank top, cardigan. And you might even end up looking like a very famous paediatrician from ER. That's George Clooney on the top right, if you didn't recognise him. Okay. Poorly infant there. If you can keep calm when everyone else is stressed and panicking because you're dealing with a very sick child, then paediatrics is for you. In the middle, children come with their families, mums, dads, aunties, grannies, brothers and sisters, and your consultation needs to include them all. I would say that parents demand much more from you as a doctor when they're worried about their child than they do about their own health, and you need to be good at explaining and very good at looking after the whole family. Over there is a neonate. You need to be good at communicating with them, so very gently and soothingly, not banging their incubator door, upsetting them. Children with disability, and then teenagers down the bottom there. Now, in my experience, teenagers' brains are hardwired very different to ours. And if you can persuade a 15-year-old to have their 4th course of chemotherapy when they don't want one, then that's a fantastic thing. Okay, at the top. Oh, I've forgotten the sheep. Sorry, sorry, it's such a nice sheep. Anyway, this is about research. That's why the sheep is there. Many opportunities for research in paediatrics. Most of them seem to involve sheep at the moment, but I'm sure not all. And rapid advances in technology in paediatrics too, particularly on the intensive care unit and the neonatal unit. Right. Okay, textbook of paediatrics. We see a huge variety of conditions in paediatrics, all adult illness, and thousands of genetic, congenital, growth, developmental conditions as well. So you'll see something every day if you become a paediatrician, and you'll never be bored. Paediatricians are true generalists, and there are very few specialties these days that can say that. This is childhood mortality at the top. You can see a dramatic reduction in deaths in children over that period, particularly under 5s, less reduction in adolescent mortality, and the challenge is that for us over the next 40 years. So good paediatric practice, I would say, has a major impact on the nation's health. Sick person here. Children get better very quickly, so they go from looking like this to playing with their toys within 24, 48 hours, which is great to see, and then they go home the same day. And if they have very exciting toys, like that alien there, you even get to play with them sometimes. Lastly, this is measured and measuring in that corner. Paediatricians are interested in how children grow, their weight, their height, their head circumference, their skin fold thickness, and also their testicular volume, if they have testes, of course. And we watch their testes go from blue to yellow, like on our Prada orchidometer there. Not sure if that happens in real life, but anyway, it does on our Okay. We're measured in our approach to investigation. We can't order 10 blood investigations and CT scan, because we might only have 2 mils of blood with which to look into what's wrong, and we'd have to do a GA for a CT scan. So we have to be good history takers, we have to be good observers, we have to do focused examination and then be measured in our tests, and I like that. I think that's proper medicine. Okay, you can see that. Most of adult illness has its roots in childhood, physical illness, mental illness. So if we look after our children well, we can throw most of these guys over the side of the balloon, because we'll need less of them. Apart from my friend Sue, of course, who in her obstetric capacity helps make more paediatric patients. Lastly, if I get to the final... I wouldn't like to say. And lastly, if I get to the final, you get to watch a minute of Scrubs, which is the best programme on the telly. Thank you.
Great. Thank you very much, Lizzie, and very convincing. So now, Tom McCulloch, ACE, histopathologist, special interest in urology. So he's the man who looks at all our prostate biopsies. Do you think that's interesting? Tom has left his lab to be with us tonight. He's only just removed his dark glasses because of the intensity of normal light. So, Tom, please tell us what's so good about sitting in a lab all day.
Thank you for that. Thank you, John, for that fantastic build-up. Yeah, I'm under no illusions here that I've been set up as the fall guy. looking at the Gillian McKeith amongst the sexy specialists in front of me and doing their exciting jobs. Well, I'm here to tell you about histopathology, what a great specialty it is. These slides here are just to remind you that it's not just all pink and blue. There's green and black and white and orange and yellow, and so it's great. And you get to work with some really good colleagues, and here are a typical bunch of histopathologists, all working in harmony, never a crossword, just like for real. Okay, so what do we do? What does a histopathologist do? Well, I mean, really, it's a bit like, people say it's like bird watching, but it's a bit more exciting than that. It's a bit more like safari. So what we're trying to do is decide what's the tigers and what's the pussycats. Sorry. Wrong kind of pussycat. Which is, that can be straightforward, but it's not always straightforward. It's a craft and you have to learn it. It's like learning a musical instrument. So sometimes a tiger is another small feline, like a pussycat on the right. The problem is that one is just harmless, and the other one will grow up and bite your throat out. So it's important to know which is which. Sometimes, of course, things come along which are very, very unusual, like a European lynx or a rare tumour. And so it's important to know what that is and to communicate that to the clinicians you're working with, because you may be the person who actually knows more about that than anybody else. Okay, so histopathology. Well, David Bogart told us that if he left the hospital, nobody else would be able to do anything. Well, I would contend that if I left the hospital, nobody would be able to do anything because they won't know what they're dealing with. So we are the specialty that has the answers. But is it boring? No. Thrills, yes. It can be thrilling. If you're sitting at looking at a biopsy and you think, if I call this cancer, the leg's coming off. That's pretty thrilling. Excitement, yes, excitement when you see something rare that you've never seen before, nobody else has ever heard of. Oh, I like that. And I like the challenge of finding new things and making sure that the clinicians understand what's important about a particular part of that disease. And of course, it's a fantastically interesting specialty. I have to say that it's something I have never, ever lost my enthusiasm for it. In 20 years doing it, it's just continuously interesting all the time. You don't normally do all of histopathology. You can specialise in lots of different areas. I do apologise for the shadow. That's because it's a different version of PowerPoint. And you get to work with colleagues, and you get great banter in the biopsy meetings, particularly the urology one. You also get breakfast, which is really excellent. And I think it's important to say that we are at the centre of the decision-making process. If what you say sort of decides what the treatment is going to be. And the good thing is you get all the satisfaction of contributing to patient care and being at the centre of that process without any of the downsides. So no on-call, sensible hours, and a good work-life balance. And if I get through to the next round, there'll be more points about what you won't be dealing with in histopathology. So that's the general tenor of histopathology. But why would I be suggesting to medical students to do it now? Well, I think that, ironically, histopathology is actually coming into its own. And that's because, really, we have better treatments. This tumour on the right here, with the 3 slides, we all know that's a gastrointestinal stromal tumour. But when I was first did histopathology, we just didn't really know what they were, kind of smooth muscly. We didn't know how they were going to behave. Now we know what they are, what they're from. We can diagnose them using the immunohistochemistry on the right there, and we can give a very good idea of how they're going to behave. We also know the molecular change that is there, and that will inform the clinicians to give exactly the right treatment. So in this case, it would be imatinib, which gives the patients a much, much, much better outlook. So along with that, we've got newer treatments, and they demand better diagnostic refinement and also estimation of newer and sexier technologies like molecular technologies and in situ hybridization. So, for instance, on the bottom right there, that's some in situ that I've diagnosed a Ewing sarcoma on. So that's the sort of thing which you'd be sort of scratching around in the past for, but now bang on the money. You can make the diagnosis very confidently. So in terms of diagnosis, it's becoming more important, and also in terms of directing treatment. So, for instance, HER2 status in breast carcinoma. Okay, so that's the boring bit. Sorry about that. The other thing is, you're all thinking, I don't want to do post-mortems, blah, blah, blah. However, as of next year, the Royal College is no longer a requirement to do post-mortems for pathologists. You can qualify as a pathologist without doing post-mortems, which is great. I haven't done them for years. I've never looked back. So that's not anything you need to worry about. So I would say histopathology is really the coming speciality of the moment, and I would urge you to vote pathology. You know it makes sense. Thank you.
Thanks very much for that explicit presentation there, Tom. Highly convincing. Now a great pleasure to have Simon Travis, who's going to tell us about careers in radiology. Simon's relatively new to Nottingham, but hasn't left yet. Simon is also someone who works in a darkened room, so it's very apposite that he follows on from Tom. Simon, thank you very much.
Yeah, you stole my thunder. I was going to say it's a bit bright in here, but there we are. That scary bloke in the kilt's got a bloody knife in his sock as well. If it turns out as a scrap, I'm on his team. I'm cheating slightly. I'm going to talk about interventional radiology because I'm an interventional radiologist, and there's a reason for that. And just in the last few months, we've got subspecialist recognition. So I'm going to give you a quick whistle-stop tour of interventional radiology, and by the time at the end of this, you'll probably know as much as me. Radiology is a changing speciality. We've got computers and we've got big machines, and we're changing by the day. Technology-driven, and we are there on the cutting edge of every speciality in the hospital. There isn't one doctor sat down here, except Tom, who doesn't use radiology on a daily basis. We are there for everything, whether it be a chest x-ray for a GP, an ultrasound scan. We're there for everyone. We're the true dynamic speciality, and we're the speciality that's growing and developing with some fantastic technology. You look at MRI scans, you look at 3D CT scans, you look at PET imaging, all new stuff, all exciting, and that's what's happening in radiology. And interventional radiology is even more exciting, and I'll tell you why. We're the ones that are taking over all the operations, all the procedures, and when the poo hits the fan, they come and talk to us. We're the ones who save the day, and we're the ones that get the drainage done, we're the ones that stop the bleeding, and we're the ones that sort the patients out. So let's have a look at what we do. 3 years of training in general radiology. Well, first of all, we've got subspecialist recognition in interventional radiology, so we are a defined speciality now, and that's a big thing, that's a huge thing. There are certain areas in the world where they've tried to take over interventional radiology because they see it as a very sexy, exciting new field, and they want that money, they want the income from that. So we've now got subspecialist recognition, which means we set our syllabus. We have got our own exams. We've got our own course. And if you want to practice interventional radiology, this is what you've got to do. You do 3 years of general radiology training where you learn how to be a radiologist, how to use CTs, how to use MR, how to use ultrasound, how to use Doppler, how to use angiograms. And then you do another 3 years of interesting training where you put wires and catheters into every organ in the body and learned how to do that. Cardiologists, they have to learn to catheterize 2 arteries. We do the rest of them. It's true. And when you start, you get a free pair of X-ray specs. Don't think I'm joking. This is what you'll be wearing soon. Okay, so why interventional radiology? Well, it is new and exciting. I can't say it enough. We are providing treatments for every speciality in the hospital. Just thinking of obs and gynae, they get a patient who's got an unexpected placenta previa or an unexpected placenta accretia, I apologise. They start hemorrhaging, and those people hemorrhage like you would not believe. I mean, those patients can die in minutes. We can get in there, we can get catheters in minutes into the uterine arteries, and we can put particles in there, stop them bleeding, prevent them having hysterectomies, and also prevent them having multiple blood transfusion. The Royal College of Obstetricians and Gynecologists recommend that interventional radiology is available because they know we save lives. We're there at the cutting edge, and we're saving lives every day. Okay, so that's why you've got to vote for me, because I'm going to show you some exciting, sexy slides later on. And I'm going to haul myself out just the same as all my other colleagues have done as well. Okay, we make a real difference to patients. Not only do we do it in life-saving situations, but we can do procedures which have immediate benefits. We can drain obstructive jaundice. We can deal with things like prostatic hypertrophy, for instance, is a new area that we're wanting to move into at the moment. More of that later. There's a wide variety of emergency treatments. This centre is going for trauma centre status. A few hiccups along the way, but one of the things that is essential to have interventional radiology. Trauma pelvises, they're bleeding like stink. Who do you call? You don't put them in you don't go to the surgeons, you don't put X-fixes on, you embolise their bleeding arteries and you embolise their venous side, so you stop them bleeding to death. You prevent massive blood transfusion. Having blood transfusion is a really bad thing to have. It shortens your life and it's a bad thing. This is an X-ray of Nick Clegg. He was just trying to talk about student tuition fees, but unfortunately got part of his anatomy stuck in his mouth. Everything happens in radiology. Okay, this is a very quick brief overview, so just some of the things that we do in interventional radiology. Uterine fibroid embolization. You can have a hysterectomy, you can have a myomectomy, or you can have an embolization. This is a day case procedure. We selectively go into the uterine arteries. We put little tiny particles in, and they infarct these fibroids. They shrink. They stop bleeding. These young women who have terrible lives, who have terrible bleeding problems, have terrible anemia, are suddenly made better by a one-day case procedure. These women come back and say, "Thank you, Dr. Travis. You've revolutionized my life. I jest ye not." They're queuing up outside. Exciting stuff like this happens. This is a carotid aneurysm. This is a patient who had been to see a GP many, many years ago, I hasten to add. She got a big abscess at the back of her throat. The GP put a scalpel on the end of his finger and said, "Open wide," and stuck his scalpel in. He made a great big hole in the carotid artery, and she came back later to have that fixed by us. This is a patient from the urology service. Had a PCNL, had a great big fat tube stuck in the kidney, pouring blood out of his bladder, absolutely peeing blood out. And that was because they'd made a great big hole in the artery, which is connecting with the vein here. I stuck some coils in there and stopped it bleeding. All done. Job done. Patient was happy, went home. So there we go, interventional radiology. We're inventing procedures for other specialities since 1973. We're taking over, we're here, and we're good.
Right. John, this advances, does it?
Yes.
No. That one and that one.
Well, thank you very much for that, Simon. I hope the audience, when they vote, will note that you did have more, slightly, than the allowed number of slides, but they were good. That's PAX for you, isn't it? Okay, now, great pleasure to have Angus Wallace in Nottingham for once. And he's going to explain to us whether there's any hope that orthopods will stop using hammers and chisels. Thank you, Angus.
Well, thank you for inviting me to talk to you. For the last 3 years, I've been chairman of the SAC in trauma and orthopedics, designing your training. So I am the authority that can tell you exactly what's happening in trauma and orthopedics, and I'm going to do just that today. It's a great career because we, contrary to what you've heard from the others, make all our patients better. 95+% of patients who have knee replacement, hip replacements are satisfied. 90+% of knee replacement patients are satisfied. 85+% of shoulder replacements are satisfied. And when we get on to keyhole surgery, which is really great fun, we can make 85% of our patients happy with the outcome from the surgery. Surgery is fun for orthopedic surgeons, and I'm going to show you later just how much fun it can be. And you have to remember to balance orthopedic surgery against the other specialties. ENT surgeons sniff, anaesthetists dream, GPs are fair, paediatricians are immature, histopathologists are dead ducks, obs and gynae doctors are late, and radiologists carry out blind studies. So what are orthopedic surgeons? They surge, and also there's a little bit of private practice as well. Now, let me tell you about the career structure, because once you've done your 2 years of foundation training, you do 2 years of core surgical training, and if you play your cards right, you go for an ST3 run-through training. That's... What have I done wrong? Right. ST3, which runs through to ST8. And that program allowed you structured trauma and orthopedic training, which by the end of ST6, you will be a broadly trained trauma and orthopedic surgeon. And then you get 2 years, ST7 and ST8, after you've passed the FRCS. Now, we're such good trainers that our trainees have an 83% first-time pass rate in the fellowship exam.
It's an easy exam.
No, we just train well. And then we spend the last 2 years doing specialty advanced training so that you actually have a special interests like doing knee surgery, hip surgery, and you have a 90% chance of getting a consultant appointment of the type that you want to get. So orthopedics is really attractive. The big problem, and I accept it's a big problem, is that step right at the beginning where you're trying to get into orthopedics after your 2 years of core surgical training. After that, great fun. And we have toys. You remember some of these toys? This is my grandson. This is him playing with his toys at home. And this is Peter James. Now, this is a vibrating toy, and you can see that Peter has that in his hand, and he's about to use it not in Sue's area, but on a patient's knee, and he's going to reshape a patient's knee with that vibrating and rotating tool. And these are the toys we have that go with that tool. These are all the implants and implant trays that we use at surgery, and they're great fun. Not quite so much fun when somebody drops something, but they are great fun. Now, we look after trauma, and we have transformed patients who have trauma care. This is a lady with a smashed-up pelvis from a car accident. And this is a bar that is put inside her body, holding the pelvis apart. And this is a picture of her with that bar in place. And you can see that bar going from one iliac crest to another under the skin and holding the pelvis apart. Now, we are very concerned about functional outcome, and the functional outcome from this new operation is fantastic, because one of my colleague's patients, Darren Forward, my son-in-law that did that operation, one of his patients managed to get pregnant with one of these bars in place. So they are extremely functional ways of reconstructing the pelvis. Now, you need to know what the second edition of this talk is going to be. I will be doing the Highland Fling while I tell you about the other strengths of my specialty. Thank you very much.
Thank you very much for that, Angus. I'm reassured by the use of vibrating instruments. And, of course, it's now very useful that Sue Ward is here in order to tell us how you can possibly deliver people who've got all sorts of bits of metal in them.
Where do we go?
Sue also had the advantage of doing urology, was a registrar here at the Queen's, an enormous benefit to her gynae practice, of course.
I haven't
so
made
thank
any.
You very much.
Haven't made any fistulas yet, John. Well, being last up is a little bit difficult, I think, because might actually quite like to do your careers now, having listened to you lot. But I came here to tell you lot, especially the medical students, what an exciting job I have. And I think I should probably start off by telling you about the first delivery I did as a medical student at Peel Street, the old women's hospital. It was an undiagnosed twin pregnancy. So I was a medical student before we had ultrasound scans. And unfortunately, we didn't know there was a second twin in there until after the midwife had given the injection to separate the placenta. So all of a sudden, all hell was let loose. The registrar came rushing in, put his hand up this woman's vagina and pulled another baby out by the breech. And I thought, God, this is exciting. I think I might do this for a living. So that was the start of a career which I don't regret a day of. I've never had a boring day at work in the 24 years I've been doing obs and gynae. And one of the reasons it's so interesting is that you get to do a bit of everything. It's a mix of medicine. We look after people with complicated pregnancies, where the mum's got medical problems or maybe the baby's got medical problems. There's a lot of surgery, And I think probably I'm a surgeon at heart because I did really enjoy my year as a urology registrar and the 3 years of surgical training I did before obs and gynae. So I think I probably went into it as a surgeon. If you like cutting, there's lots of that. And it's extremely exciting cutting some of it. You've heard about massive hemorrhage on the labour ward. They're still going to need us, even when you've got little coils to fire up arteries. I've got little coils too, but they've got a different job in obs and gynae. To prevent people getting onto the labour ward and getting major hemorrhages. Anyway, it's a little bit like casualty because it's quite exciting. Things happen very quickly. Our decisions make a huge difference to the health of your babies. So what I do, I think, is absolutely crucial. And I don't think you could be possibly doing a more important specialty. Quite a lot of psychology in obs and gynae. I think you notice that when you start training in it more than anything. And occasionally our patients get puerperal psychosis, so we need to learn a bit of psychiatry during our training. So it's a big mix of everything. Now you might say, well, that's probably because I'm not very good at much. Just, a jack of all trades. But it makes the specialty very, very interesting. I do a huge amount of teaching, which is something that obs and gynae are very keen on. We're very good at training our trainees, I would say that, as a training programme director. And there's a lot of research available. This, for instance, is a human papillomavirus. Those of you who've got teenage girls will have seen your girls go through the vaccination programme over the last year or so to prevent them getting a cancer of the cervix. So the message is it's a good mix of interesting things to do. Obstetrics is probably one of the most important things you could be doing. So if you get to be me, you get to do forceps deliveries, you get to do caesarean sections. I'm just wondering how on earth we're going to get a baby out of that pelvis with the bar across it. Because I think the forceps might hit the bar, and the bar's exactly where we put our section scar. So this is going to be a classical section, I think. So we do a lot of this. Those of you that are very observant will notice that baby's got 6 toes. So you can get good at ultrasound scanning, feto-maternal medicine. That's a 4D scan at the top. The baby's giving you a little gesture there. So it's quite an interesting thing to be doing for a living. Or if you like surgery, it's pretty interesting surgery. This is a patient who we thought had a torted ovarian cyst. It turned out to be a torted hydrosalpinx, so we get lots of surprises, especially in Mansfield where I work. This is a poor patient with a massive prostodenture, which we're about to do a vaginal hysterectomy on. So it's a good mix of things. There's urogynecology, there's infertility surgery, there's fibroids to operate on rather than embolise. So it's an interesting thing to do if you like surgery, and it's a hell of a lot easier to get into than surgery, not quite so competitive. And not only do we make sure these little chaps get out safely, he's giving you a wave there, we make sure that their mums get out of the labour ward safely. So what we do is partly about getting the babies through it, but partly about getting the mums through it. These reports here, these triennial reports, are about what women die of in relation to pregnancy. Now, you probably don't think that it's reasonable for women to die of pregnancy-related conditions. We certainly don't. These are the sort of things they die of. Every 3 years, we read these reports with a lot of interest to see if we can change anything in our own practice and our own labour wards to try and prevent this happening. But there are still about 100 deaths a year related to pregnancy. So we'll be teaching you to do stuff like deal with major hemorrhage. We'll be teaching you to do stuff like deal with eclampsia before she has a fit. The next report, which is about to come out next week, sepsis is at the top of the causes of maternal death. So we certainly haven't beaten the Grim Reaper yet, but we're still working on it. And why have I got a picture of the Taj Mahal? Mumtaz Mahal died of postpartum hemorrhage, having her 13th child. So if it hadn't been for obstetrics, we wouldn't have a Taj Mahal. I rest my case.
Well, thank you very much indeed for that, Sue. Now, we've just got to load up the voting thing, which has got... What? What? I'm quite sure Angus won't vote for himself, being a gentleman. Now, how's that balloon going? Is it falling close to the floor? because we're about to be able to chuck out some people so that it will float higher again. And you will have noticed the very realistic artwork there of the presenters this evening. Now, voting, you've got your keypads with you, and you've got the names of the people who presented this evening, each annotated with a number, and you simply have to press on the number, that's all. Has everyone got a keypad? There are more. Does anyone want to give? Have you got one? You've not got one. Do you want one? Mr. Manning. He's gone. Okay. So I think that we've had a fabulous lot of presentations there. You will now be digesting what you think is going to be the ones that's going to get your vote. If I'm right, all I've got to do is ask people to vote, isn't it now, Phil? So take your time, do it thoughtfully, and you only get one vote each, so start voting now. Very tricky.
You can't change your mind, it's the last question.
Oh, is it? Oh, we won't let them do that. Phil, there's nothing happening. Oh, we've just, sorry, just keep, you might have to do it again. Getting tense. I have to say I've been very happy with a career in urology, because actually urology spans absolutely everything that all the people here have spoken about. Plus it makes people much better. Sorry, just a slight bit of technical thing. It was working perfectly earlier on. That's the one. Brilliant. Okay, I suppose while we're just waiting, are there any questions that you might like to ask the presenters? We have got time for one or two. That's all. No questions. Everyone's completely bamboozled. Have we convinced any of the audience that, in fact, they would like to come out of retirement and go back to a second career? Doesn't look like it. It's working. Okay, it's definitely working now, so you can do your votes again then. Sorry about the blip. That's it. I can see the numbers accruing, and very rapidly too. Always a cliffhanger. And have we got any people from Baltic states here to skew the results? Okay, it's not rising up. Is everyone happy they've done their votes? Because we're going to now see what the result is. So, now, there we have it. So, actually, that is interesting, isn't it? Travers, by a fairly significant number, has come out as the winner. After that, we've got Lizzie Didcock, 16% of the votes. And then we have got David Bogard. That is astonishing. So, Okay, so that's great. So, so the three speakers now, I think we'll go in the order of, if you wouldn't mind. We'll go in reverse order then. Okay, so we'll have Travers first, then Didcot, and then Bogod. Is that all right? So, if you would like Simon to come and take your place here again now for your next talk.
Just come out of this one, just leave this one open. I see what you mean, yeah.
Yeah, we'd only need to just reduce it. Yeah, minimise it then. There we go. Good. Thank you.
Can we time it this time? Not geological time.
If you press that button like mad, you get loads of votes, I'm sure. 'Cause that's what I did. I was pressing it like fury. I'm sure that's a secret. Wow, okay. Back to the second round. Well, thank you for voting, if you did. If I managed to do it just by pressing that button lots, then good for me. Interventional radiology. I got this quote off the internet. I was having a look and I wanted a sort of snappy definition. I'm not sure this quite fits the snappy title, but interventional radiology is a medical doctor who has completed higher degree in radiology for full understanding of imaging devices, imaging interpretation of body diseases. The interventional radiologist then spends 3 years in training to manipulate special delicate medical devices inside the body under image guidance to treat a wide variety of diseases. And we've said before, there is a huge variety of diseases. Now, then I've got some photographs. It is one slide, but I'm going to get lambasted for giving loads of slides. He's an interventional radiologist. Look, he's happy, even if he's a slaphead. He's happy because radiology is sexy. It's really sexy. Okay? He's achieved his goals, all right? He's got there. He's happy. He's done everything in life he wants to do. And radiology rocks, man. Okay, last slide. Last picture of the one slide. Just a quick go at my host here. Here's a motley crew. I went to Lisbon 2 weeks ago to discover how this professor of interventional radiology, see, he's a happy one there, he's treating benign prostatic hypertrophy. He's treating patients who have terrible lifestyles, who are up every night with urine retention and unable to PU. And he's treating them with a day case procedure. He's embolizing their prostates in the same way we embolize fibroid uterus and a lot of other diseases. He's happy. He's happy. He's a research fellow. He knows he's got a job to go to. I'm happy. I've had a jolly out to Lisbon. He's a urologist. Thank you.
Thank you very much for that again, Simon, and the explicit use of more than one slide.
Multiple photographs, one slide.
Yes, I understand. And if you're looking at MRIs with about 1,000 images, I can understand how you think like that. So thank you very much. So fabulous that Liz has been second place in the first round, and Liz is going to convince us more about paediatrics and maybe tell us why the other ones aren't so good.
Sorry.
And
What do you want me to do with that then?
just minimise it, I think.
Right. Paediatricians aren't very good at technology. Oh,
It's not bad. We can do this. We can do this.
Right, while we sort this out, I haven't got very much else to say. I'll come round here, because I think I've said enough, and certain colleagues have said far too much. Over far too many slides. Thank you. Right, so all I'm going to do is to show you 1 minute of Scrubs. How many of you watch Scrubs? Okay, fantastic. Right, there's only one paediatrician in Scrubs. He's not on very often, but this is a paediatric consultation, very similar to what happens in Queens and in Strelly, where I work also, most days. Right, hold on then. Volume, hang on. Might have to go back in. It's a shame. It'd be even better when you can hear it. Otherwise I'm going to have to...
I think, Dr. Norris, what we're looking for is someone who's not too alarmist, but also not too lax either.
Oh, God, please let that someone be me.
Look, you're obviously a little busy with your doll.
My doll! It's a collectible.
Someone's gonna get his ass bit.
Right, I think we should probably take over. We're going to be back to you with our decision.
Super. I'll be by my giant pretend phone pretending to give a crap.
Oh, by the way,
Hello? Uh-huh. Uh-huh. Hello?
Of course you do. He's you. And nobody loves you more than you. You know that.
you know, still, he is the best pediatrician on staff, and since we both work here, we can have a lot of pull over. I mean, come on, Jordan. You haven't let me make one decision about our son, which is why, by the way, you'll be doing the answering when he asks, why Daddy's wee-wee doesn't have a turtleneck on it like his.
Yeah, fine, whatever you said.
Thank you very much for that. Novel, I have to say, and inventive. So, finally then, David,
Yes.
the floor is yours, of course.
Of course.
I suspect you're lagging far behind the others, so there's quite a lot to make up.
You wish.
But no doubt you will. Thank you very much.
Thank you very much, John. I really wasn't expecting to be up here for second round. Anaesthetists are naturally self-deprecating creatures. modest in the extreme, and are often known as the Jeeves of the medical profession. And really, what I wanted to say was you've very rarely heard so much rubbish from so many well-paid people in your life as you have this evening. Even from me, the reason I became an anaesthetist, and I will be honest with you here, please don't let it out of this room, is that anaesthetists seem to be a pretty cool bunch of people on the whole. When I was at medical school, they were the only group that I worked with who didn't insist you called them sir, and they let you do things. It was quite wonderful. And several other anaesthetists have said that to me in the recent past as well, that anaesthetists just seem to be quite nice blokes. We do have a self-deprecating touch to us, but not only us as well. We've even come under the purview of someone like George Bernard Shaw up there, who, when put into the mouth of one of his characters from The Doctor's Dilemma, the immortal lines, "Chloroform has done a lot of mischief. It's enabled every fool to become a surgeon." And I don't think many of us would argue with that. Speaking of cool anaesthetists, of course, the chap at the bottom right-hand corner, many of you will recognise as Richard Gordon, the author of The Doctor in the House books, but you may not know his professional name was Gordon Oslerer, and he was an anaesthetist as well. And he is credited with describing anaesthesia in that self-deprecatory way we have, as the half-asleep watching the half-awake being half-murdered by the half-witted. So, finally, I really just want to say you shouldn't throw the anaesthetist out of the balloon. The anaesthetist is the only one who has any knowledge of pressurised and inflammable gas. You may think, and I assumed that Angus Wallace was going to make it through to the last round, but you might think that Angus would be a good person to have in the balloon purely because of his, the amount of hot air he can produce. But I have to say to you, how many of you would want to be standing under that balloon as the loosely woven wicker basket went overhead if Angus was dressed like that and still in it? Thank you.
Great, well that's fantastic. Now we've just got to get Phil just to put the names into our final voting slide. And I should think you're all pretty tense about it now. I think those were very good final presentations. Again, Simon taking a slight liberty with a number of slides, but it is very interesting, isn't it? And we have to just think of a chap looking at 4 million little pictures every day and what that does to your mind. Lizzie with her evocative clip, which I think was excellent, beautifully done. And I think that that's a great credit to do that. And David Bogod, just a slight bit of intellect, I thought, there. Something which does occasionally flare up during the operating list when it gets close to the end of the operating list. So, are we...
very rarely get close to the end of the operating list.
So is that it now, Phil?
Oh, I've changed my name.
Bogog. No, don't touch anything. Don't touch anything. I like that. I like that. Possibly that's something that will stay with you forever. So, you can all vote now then. So only 1, 2 and 3, please. If you press 4 or 5, it'll be trouble. This is terribly Eurovision, isn't it? Okay, that's it then. That's the last lot of votes, nearly, I think. So, let's see. Oh, no! I can't believe it! I simply overwhelmed. So I think that's fantastic. Well done to the three. Well done to the 3 finalists. So well done to you, David, particularly. Simon, second, and Lizzie, third. I think that's fantastic. How's the balloon gone, Sharon? We're taking the last lot off, and it'll float back up again. I think that's wonderful. So I think I could now ask Our Lady President if she would perhaps present the first 3 prizes, I think, if you wouldn't mind. So thank you very much. So, wonderful. David, would you like to step this way, please? Second place, Simon.
The last person here was Tim Roberts with a gold medal around his neck, and I found something that looks a little bit like a gold medal. It's got gold on it, but it's actually a perfectly matured Marks and Spencer's Christmas pudding.
Brilliant. And then our last finalist, Lizzie Didcott. Fantastic. And actually, I thought she was the winner. That's it. That's great. That's the end of the balloon debate. So I must thank again all the participants for it. It's been a fantastic effort, actually, to do it all.